We have Dr. Jack, Dr. Ely, Superintendent Thielman, and Dr. Bregan. So we'll start with Dr. Jack. This PCR test seems to be one of the biggest problems with trusting the data being reported by the CDC. What can you tell us about the problems we've been hearing about the COVID PCR test?
Yeah, first, I absolutely will. I'm going to give you guys some slide presentation in detail that you'll never forget. But first, I want to address Dr. Martin's view and my view on this. You see, if society wakes up and says, you know, based on Dr. Henry Ely's paper, that there's a massive conspiracy theory and epidemiologists, state epidemiologists, every public health official all across the country are all in bed with Wuhan, this is not going to fly. What we have to do is we have to say Dr. David Martin's dossier is a stunning indictment on people who set this up. And what I meant by disagreeing was on the very specific motivation, specifically on why they won't budge on the fact that we have a flawed PCR test. They screwed up the test. They stumbled all over themselves. They would have had the cat in the bag 100% if they didn't ship out that test. They wouldn't need any commercial tests at all. It was Anthony Fauci, in fact, who said, I guess we're going to have to turn to the commercial test. So if CDC flipped out a test, they'd have the license on it. Everybody would have to license to CDC, and they'd be the richest organization on the planet. So it's absolutely willful misconduct at the highest levels. And I totally support Dr. David Martin, but I want to be, because the way that information propagates through social networks and so on, your head can be spinning on how could there possibly be such a massive conspiracy. The people in the middle, they really don't know what's going on. They're good soldiers. There's an emergency. You have to run the test this way, or it's going to get out of hand. And that's the distinction. It's a subtle distinction. But I'm going to cut right to, if I may, cut right to the presentation that I have here.
Please.
Thank you. Okay, so what I've done, and this is IPAC Research, independent research organization. When we talk about deaths and diagnosis, and when the middle ground epidemiologists say that there's no false positives, there's such a wide different number of definitions of types of false positives. You can have the false positive of the test. You can have the false positive of the test in the lab with artificial sequences. You can have the false positive of the test in the field on real patient data. And you can have a theoretical estimate of the false positive just by doing BLAST, which is what FDA asked for. What I'm going to do is I'm going to show you every factor that has to be considered to understand the accuracy of the assessment, the ascertainment of the death. So this is about the diagnosis in the situation where there's a death involved. It also is directly applicable. I was on top of this way back in April, and you can go watch the Unbreaking Science episode, CDC's Deadly Testing Fiasco. And you'll find there that Chris Meekins is a whistleblower that came out and said that CDC actually lied to the President of the United States over readiness of tests. They were stumbling all over themselves. But here we have this is going to be a big decision tree. We have somebody who's died. They have a COVID-19 test before or after their passing. The test is positive, or they were tested and it was positive. This implies that the virus is present, but that actually, in this situation, it means yes, in this particular patient, the virus was in fact present. In this particular patient, the virus was in fact viable, and in this particular case, the virus caused the death. We know from other published research, this is not my research, but other published research, that the CT value itself, if you set the CT threshold too high, you're going to end up with false positives and non-transmissibility. You're going to end up with deaths that are not attributed, that are attributed as causal, but they're not causal because even though it tested positive, the person didn't die from it because the virus wasn't even viable. And the World Health Organization's recognized that the PCR CT scores have to come down. This is their notice. This is the Sentinel article showing that Kansas actually did the same thing. They're bringing the CT scores down, and I expect state after state is going to start dialing back their CTs. So in this decision tree, if the virus was present and the virus is viable, it still could be unrelated, such as in the situation of a person that has COVID-19 who's killed by a shotgun blast. So that death should not be attributed. We just heard about that. That was a brilliant point. But we also have, in that case, would be a false positive. So in the very first category, we have the true positives, and then in the second category, we have a false positive because the virus was not viable but unrelated, and then we have the virus was present but not viable. That's another category of false positives. And then we also have the fact that the test might have a false positive rate itself. This is the clinical test false positive, the technical false positive rate that we're talking about. Everybody else talking about false positives hasn't even addressed the other two categories of false positives. So with the virus actually being absent, but the test scoring positive, those are the rates that are published by Bacille and Lee and Wernicke, and they're a stunning indictment on the use of PCR just to detect the virus, let alone to do the clinical diagnosis and the mortuary analysis. So here we have an example where, yeah, the person's tested, but the test was negative. And then we have, of course, the possibility, well, the virus isn't there, but there's consequences there. Another category that joins that test negative are people that aren't tested at all. There are people that die. They're given a COVID-19 test. No, they're not given a COVID-19 test. So we're going to call those test negatives as well. And then this is where the presumed positives come in. This is where Dr. Ely was referencing earlier, that the test is assumed to, regardless of the test result, if they're not tested, you can go ahead and assume any respiratory illness is COVID-19 with the financial perverse incentive. That is going to turn out to be something where it's complex, because in fact it could be a true positive. Because they weren't tested, we don't know. The virus could be present. So we're going to put that back to this category where the virus is present, and it can either become a true positive or still two categories of false positives. Here we have the presumed coronavirus fatality, but the virus was actually absent, and that's going to be a false positive. And that also plays into enhancing these false positive rates, because these are, again, are just the clinical, the technical false positives of the test. Now, if you have a negative test, either because you weren't tested or the test turned back negative, if you don't presume, if you overrule the prescription, the mandate to presume all deaths due to COVID-19, if unotherwise specified, if you have another reason, like Dr. Scott Jensen estimates 25% of his cases that he's looked at that died should not be considered COVID-19 at all, then the virus could still be present. You could be wrong. And then it becomes the question whether or not it was a causal factor or not. And then the other category is the virus is present, but it was unrelated anyway. And then, of course, if it's not presumed and the virus is truly absent, we have the true negatives. What I've done here is fleshed out the entire tree of possible combinations, and you can see there's the true positive. There's one route to two positives here, a circuitous route through the presumption pathway. There's, I count 4 different categories of false positives, a false negative, and then 2 categories of true negative. What this represents is an irreconcilable number of ways to get this wrong with CDC's algorithm. CDC's algorithm should absolutely have invited public comment, so people like me and the hundreds or thousands of other people around the country that are involved in clinical diagnostics, have developed clinical diagnostics and biomarkers, could point this very scenario out to the CDC way back in March and ask them, what are you thinking? This is madness. Look at what's going to happen to you. You have to make sure that you have 0 false positives, and you can't just claim that you have 0 false positives because the prevalence is low. This is the reference I wanted to say about we need to basically replace the CDC. Plan B, Public Health Infrastructure and Operations Oversight Reform for America. The CDC is not in any way, we heard it tonight, interested in any other cause of morbidity or mortality in the United States other than pathogenic illness that they might be able to prevent the diagnosis of with a vaccine. This is a massive, massive mistake on the part of the United States of America. So my ask is that every American citizen contact their congressman and their senator and say that take a look at this, send them this paper. It's freely available online. It's peer reviewed. Send it to your representatives and say, we really need to find out what the major causes of morbidity and mortality are in the United States, and how do we reform the way we conduct ourselves in the United States of America that take all of those concerns into play. I'm not going to go into details, but basically what we end up with is a neural network arrangement of entities scattered across the country that can't do anything but learn. But the most important point here is that at the end, this is depoliticized. It is distributed all across the country in a way that is decentralized. And the President of the United States and the Vice President of the United States, who's President pro tempore of the House, is informed on what the policies are. So it can never become public health, your wellness, your medical wellness can never again become a political commodity. It is already a financial commodity, but look into Plan B. It's an absolute essential reform in the United States. And our goal to help out here, Dr. Ely's on it now. We were not collaborating before the publication. We are now on a committee that is overseeing this particular nucleic acid technology evaluation consortium. We're going to outfit Dr. Singhang Lee with a workflow, access to clinical resources throughout New England, access to the resources he needs to actually sequence more of the clinical samples. There's not enough sequencing done in the United States, and everyone knows it. To do sequencing by his method, which he assures us will actually tell us what's present in the sample and not just tell us it's COVID-19 or not. It will also tell us, based on my prompting, to include primers for other pathogens so we can see if it's influenza A, B, and others as well. Dolores Cahill also prompted this. There are many people on the consortium. It's at the IPAC website. Our initial goal is 133,000 to just fund Dr. Lee. The overall consortium the goal is 300,000, so we can outfit him with a next generation sequencer so we can do the whole genome sequencing of pathogens as well. And so you can find the Nucleic Acid Testing Evaluation Consortium at the IPAC website. This is the pictures of the people who've joined on the consortium. We're a pretty close-knit group. I'm all business about science. And hope to make these things a reality, and we need your help.
Wow, Dr. Jack, thank you. And I commend you for diving so deeply into the most granular of levels with the data disaster we're revealing today, as well as providing a solution now. So that's what's so encouraging about your work. And of course, this event is we're going to empower you listeners with a way to contact your elected officials and disseminate this information very easily. So stay with us. The call to action is coming soon.